Assalamu alaikum. Today's lecture is about temporary pacemaker in ICU, the first part in this series, and it will cover transvenous temporary pacemaker. Temporary transvenous pacing is indicated for reversible condition where the permanent pacing is contraindicated. And one of the most common causes of temporary transvenous pacemaker insertion is hypothermia induced bradycardia. Other conditions like post-cardiac surgery, if we have injured SA node or conduction system, we can and the non-working or problem in the epicardial leads, epicardial pacemaker, so we can use transvenous pacemaker. Also, cardiac or chest trauma, if we have EV node dysfunction or SA node dysfunction, it also will need a temporary pacemaker. If there is, we have bradyarrhythmias which are arising from metabolic and electrolyte disorder. Some of drug-induced bradycardia or bradyarrhythmias we can use a temporary pacemaker till we get rid of the drug from the body. Another indication of temporary transvenous pacemaker, not only bradycardia, but they are also used for managing patients who have tachyarrhythmias. Sometimes we can use overdrive pacing for effective prevention or treatment of postoperative atrial flutter or monomorphic ventricular tachycardia. In some cases, prevent torsion de bois, which is bradycardia-dependent tachycardia. It's important in this case. What are the reversible causes of heart block? It's important to emphasize on this point. That's maybe postoperative after especially after coronary artery bypass. Sometimes junctionalism after valvular disease, valvular operation, presence of trauma for SA node or AV node causing this dysfunction, electrolyte issues like hyperkalemia, presence of disease like Lyme disease, all of these can cause reversible temporary heart block. For temporary pacing, transvenous pacing is contraindicated for patient who has a symptomatic patient with a stable rhythm with no clinical symptoms, presence of a stable rhythm as a first degree AV block or a stable escape rhythm. A patient with when we pace patient for a stable rhythm, so that will lead to a high risk of dependence and potential for patient-induced asystole if we stop the pacemaker. And types, there is a standard pacing leads which is bipolar, typically to 3 to 6 French in diameter. It needs fluoroscopy for insertion. The second one is a floating, which is balloon tipped and useful to be inserted without the need of the fluoroscopy. Semi-floating, responding well and easily to be manipulated well, easily appropriate for manipulation. Here is the floating one or balloon tipped pacemaker, which is used the same like insertion of Swangans and used if there is no fluoroscopy. Of semi-rigid catheter, it's stiff and it easily to be manipulated with fluoroscopy. Techniques for lead replacement. Floating catheter will follow the blood flow into the right ventricle. Once reaching the right ventricle, we will deflate the lead and prevent it from reaching pulmonary artery. Single pass EV sequential pacing catheter will show proximal electrode for pacing, atrial pacing, and the distal electrode for ventricular pacing, which means AV sequential pacing, one for the atrium and the one for the ventricle. Third thing, pacemaker, so you should expecting some complication. First, complication of the venous axis, pneumothorax. It's more common with the subclavian. The same is hemothorax with a subclavian. Infection will be more with femoral uh, venous axis. Thrombus formation, pulmonary emboli, significant bleeding, especially with subclavian to avoid the difficult of compression, air embolism, and nerve injury. Maker capture, like loss of capture, like generator malfunction, battery depletion, or generator error, lead and contact issues like inflammation, fibrosis, catheter dislodgement, physiological conditions like electrolyte abnormality, hypoxia, and acidosis, which decrease the sensitivity for increase the threshold to stimulate the myocardium. Device displacement like lead displacement or lead fracture. Pacemaker capture appropriate EV pacing to have effective pacing for an EV sequential mode. So we should have effective sensing. So if there is no effective sensing, so there will be ineffective pacing. Under sensing in EV pacing, if we have EV pacing fail to detect the intrinsic ventricular activity, so there will be an effective pacing. Loss of capture, if the ventricle ventricular pacing will fail if there is it fail to capture due to undersensing or the presence of oversensing in the ventricular pacing. That's mean when we interpretate the noise activity as it is intrinsic activity, so the ventricle start to pacing, and this will lead to oversensing. Tachycardia caused when we by right atrial manipulation. Non-sustained VTAC, which will happen if we go rapidly into right ventricle, and it will resolve spontaneously if we withdraw the catheter. Sustained VTAC, which require immediate medical intervention. It can be non-sustained VTAC can generate it to VF and lead to life-threatening condition and need defib. Of catheter insertion is myocardial perforation, and it ranges from mild to severe. If it's severe, can lead to cardiac tamponade and need urgent precardial window and evacuation. Also, it may indicated by specific sign like severe hypotension, ECG changes by change in QRS. Echo will show picture of tamponade. We can withdraw the catheter if the perforation is small, or shift the patient to OR if there is a sign of precardial tamponade. Pacemaker, we will have ECG analysis to confirm the site. And in ECG, you will see QRS complex showing left bundle branch block morphology, and the lead are located in the right ventricle. And also, we can confirm the presence of the wire by X-ray. X-ray to confirm the lead position in the right ventricle in proper site. Active lead fixation. This will be in patient with infective endocarditis or device-related infection. The patient, especially in patients who are dependent on pacemaker, so it will be difficult to use femoral site for 2 weeks or more till the antibiotic finished, as the patient will suffering from DVT. Will be limitation in the mobility of the patient. So in this case, we will use the lead of a permanent pacemaker to be entering through the internal jugular, and the lead is fixed outside the body to the skin. Then we connect the patient to the battery for the battery, so the patient can easily mobilized, and there is no risk of infection. And then after the infection resolved and the condition of the patient resolved, we can reinsert permanent pacemaker again from the subclavian side. Here is a video for insertion of transvenous temporary pacemaker under fluoroscopy. We can see the femoral head, and the vein will be medial to the artery. We can take the pulsation of the artery medial to it, then 90-degree and put insertion of the syringe under flush-like insertion of a central line. Also, we can use sonar guided. There are another venous access like subclavian, internal jugular, depending on the case. Getting the access, we will go with the wire parallel to the vertebral column and go smoothly, no crossing to the midline. If we have any advance or any resistance, we will drop it back, as maybe the wire go to one of the tributaries of the vein. So we go back and advance it more smoothly. After advancing, we should go more slowly than that, because if we go more rapidly, we will have a first to avoid perforation. Sudden advancement of the wire inside the RV will lead to non-sustained VTAC. If the patient also has heart block and the heart rate less than 30, so that will lead to non-sustained VTAC asystole. So it needs to be more slowly to avoid this is perforation for the thin wall of the RV. Now the wire is passing the annulus of the tricuspid into the right ventricle. Here the view is to confirm the presence of the wire. Retrosternal view to avoid the entering of the wire into coronary sinus, and all of these monitoring through monitor to see the spike on the monitor. This is the shape of monitor in cath lab after inserting the temporary pacemaker, temporary transvenous pacemaker, showing that presence of a spike and wide QRS complex, meaning that this is a good capture for the pacemaker. The references of this lecture, besides the videos, are provided by Dr. Shireen Sami, electrophysiologist in National Heart Institute. Comments and questions can be posted down in comment.